Morphological types. This is with respect to imaging. You can always say, they'll ask what is the imaging picture of bronchiectasis. So, usually what we see is a cystic bronchiectasis followed by cylindrical or tubular bronchiectasis. Tramline appearance, you call it. Varicose is rare with saccular and followed by tubular, followed by varicose. These are the morphological types of bronchiectasis. Causes of bronchiectasis starting with ciliary dysfunction, cystic fibrosis genetic condition, primary ciliary dyskinesia cardiagenesis and primary hypogammaglobulinemia. These are theoretical aspects. As I told you, recurrent pneumonia, especially whooping cough or measles in pediatric age group. History of, you have to ask history, past history. As I told you, tuberculosis, it's a tuberculous sequelae. In adults, this is a suppurative pneumonia which can progress to bronchiectasis, pulmonary tubules and bronchial tumors are also prone to have bronchiectasis. The last one is allergic bronchopulmonary aspergillosis causing asthma. It is called ABPA. What is a pathology? These bronchiectasis cavities are usually lined by granulation tissue, squamous epithelium or normal ciliated epithelium. The deeper layers of the bronchial wall and there is inflammation followed by hypertrophy of the bronchial arteries, which is followed by chronic inflammatory and fibrotic changes usually surrounding the lung tissue. Clinical features. What are the clinical features? What is very important is any patient coming with copious sputum production, massive sputum production, 1 cup full of sputum, 1 glass full of sputum in a day, it is almost always bronchiectasis. The next one is there can be recurrent respiratory infections. That's what I said, told you. Recurrent respiratory infections and copious sputum. Hemoptysis. Recurrent respiratory infections, hemoptysis, copious sputum. Definitely there is no other diagnosis, it is bronchiectasis. Apart from that, there is accumulation of pus in the bronchi, secondary infection, which can cause halitosis and shortness, dyspnea. The patient can have dyspnea. Due to inflammatory changes in lung and pleura surrounding dilated bronchi, you can have fever, malaise, increased cough and sputum. Recurrent pleurisy very rare. If it is in the same site, then you can always one-time pleurisy followed by pleural effusion. It could be a pneumonia going for a consolidation, going for a synpneumonic effusion or a parapneumonic effusion. But recurrent pleurisy in the same area, suspect bronchiectasis.